Okay, shift gears, talk about aortic valve. So let's talk about aortic stenosis. Now, as I told you in class, stenosis is a pressure lesion. Aortic stenosis can be hereditary or acquired. Depending on the age of the population, calcific aortic stenosis is usually disease of the elderly. We see it in people that are in their 70s and the 80s. The hereditary aortic stenosis, we see them in congenitally bicuspid valves. Usually they manifest when they're 50 or 60. Now, where's the problem in the aortic stenosis? You have a gradient between the left ventricle and the aorta. The aortic valve is stiff. The left ventricle has to generate a lot of pressure to open up that aortic valve. So as that obstruction gets worse, the left ventricle has to compensate by generating a lot of pressure to open up that valve. Eventually, the left ventricle won't be able to do it. And this is when the patient becomes decompensated. So a little bit of clinical anatomy. This is your typical bicuspid aortic valve. So normally there's 3 cusps, as you can see them here, 1, 2, 3. Here you only have 2, 1, 2. There is a raphe. This is where the cusps are fused, but there's only 2 cusps that are functional. Rheumatic disease, usually you see thickening around the edges of the valve. And the calcific disease, you see these calcific deposits on the valve cusps. And this is what we usually see in patients that are in their 70s and 80s. Okay, so how does the left ventricle compensate for the pressure lesion? The way that the aortic valve, the ventricle compensates for the pressure lesion is that as your pressure goes up, what you want to do is you want to keep the strain constant. So if the numerator goes up, the denominator needs to go up. So H is the thickness of the left ventricle. So as the pressure goes up, the thickness goes up. That's a very, very simple compensation. A beautiful formula, makes a lot of sense. And here, this portion of the slide just tells you how we grade these different left ventricular hypertrophies, whether it's concentric, whether it's eccentric, or whether it's concentric remodeling. So this is a little bit more clinical. You can tack it away until you go on the wards, but that's helpful. Now, this is your normal heart. This is your hypertrophied heart. And this gentleman here does quite a bit of lifting, obviously, because his skeletal muscles have grown quite a bit. Now, one can argue whether this is healthy or not, but I can guarantee you that there's no argument that when the left ventricle hypertrophies, this is not healthy. Because not only you have too much muscle to feed, you also get fibrosis. And the contractility of this ventricle is not normal. So not only, and then diastolic function of this ventricle is not normal because it becomes stiff. So the pressure lesion of the aortic stenosis, just because the ventricle becomes thick, does not necessarily mean that this is a healthy thing to do. Okay, let's talk about pressures. So again, normal pressures, 120/10 on the left ventricular side, 120/80 on the aortic side. Look at what happens when you have a patient with aortic stenosis. The left ventricular pressure, now you have to generate a gradient across this valve to open up towards the blood pressure of 110. So if there would be no gradient, or I'm sorry, if there would be no aortic valve stenosis here, then the systolic left ventricular pressure would be 110. Now it's 200. So it's generating 90 millimeters of mercury first to open up that valve. And then it needs to generate 110 millimeters of mercury to push the blood out. Now notice, remember what I just said about fibrosis. Look at the diastolic pressure of the left ventricle in normal heart. It's 10. Notice what's happening here. The left ventricular and diastolic pressure is 25. Why is it 25? Well, because look at the muscle. It's become thick. It is not pliable. It doesn't want to relax. The left atrium has to push the blood into a less compliant ventricle. It's doing it at a higher pressure. So not only you have the systolic left ventricular pressure that's elevated, you also have the diastolic left ventricular pressure that's elevated. And this is left ventricular end diastolic pressure, to be exact. Okay, let's look at the pressure waveforms. So this is what we see in the cath lab. This is the aortic pressure. This is the left ventricular pressure. Look at how much more you have to generate of the pressure in the left ventricle to open up that aortic valve. If you go to this cartoon, this is where the aortic valve opens. But in order for the left ventricle to open that aortic valve, look at how much pressure it needs to generate. So all this gray shaded area right here is the gradient between the left ventricle and the aorta. And this is what makes that heart muscle grow in size and becomes very thick. Okay, let's look at the pressure volume loops. We've talked about this, and I showed you what happens if this is normal. As you go up in the afterload, if your contractility curve doesn't change, look at what happens to the pressure volume loop. It becomes very thin, and the stroke volume here obviously is less. I mean, goes from here compared to that. So clearly there's less stroke volume, so the ventricle needs to compensate to improve that stroke volume, and there's a variety of methods that the heart does that. Usually it has to do with changing peripheral vascular resistance in order for the ventricle to pump easier. Now, again, going a little bit more into clinical realm, if you would have an isolated system for the aortic stenosis, so you have a pump, a pipe, and a closed system, and you obstruct the pipe, whatever happens after that obstruction in the pressure world, it will drop. Now, in a human, this is a little bit more complicated because a lot of these people are elderly, and so their vascular compliance is less. Their peripheral arteries are stiff. So their blood pressure actually sometimes is elevated. And so you have to have it's very hard to treat these people because you have to make sure that their blood pressure is controlled. Because obviously, if your ventricle has to generate 90 millimeter gradient to open the aortic valve, and then your systemic blood pressure is 150, then the ventricle has to generate a lot of force to propel the blood. So we have to carefully control these people's blood pressure because you don't want to drop it too much, because then you have trouble with maintaining the stroke volume. So this is the interplay of patients with aortic stenosis. So pressure lesion, the left ventricle has to generate a gradient between the left ventricle and the aortic in the aorta to open up the aortic valve. Okay, let's talk about aortic regurgitation. It is a regurgitation, so it's a volume lesion, but there is a little bit of caveat here, which I didn't cover in class because I was trying to keep it simple. How do we get aortic regurgitation? Usually it's a consequence of dilated aortic root. Could be endocarditis, where the valve is destroyed. Congenital bicuspid valves can cause aortic regurgitation, so there's a variety of etiologies for it as well. Now, the blood leaking is from the aorta into the left ventricle. Now, it's a little bit different compared to the mitral regurgitation, because there the blood is leaking into a lower pressure chamber, because the left atrium has less pressure than the left ventricle. Now, here you have aortic blood flow going from the aorta into the left ventricular cavity. The left ventricular pressure is higher compared to the left atrial pressure. So the interplay is a little bit different. The increase in volume causes left ventricular dilatation. So this is your eccentric remodeling. It compensates for the volume increase, very similar to mitral regurg. But there is an additional caveat here. Because the stroke volume goes up, because the volume that the left ventricle is seeing, it goes right back out into the aorta. So the stroke volume goes up. Because of that, the arterial blood pressure goes up. And so if your arterial blood pressure goes up, that's afterload. So the ventricle not only is seeing the volume lesion because of the leaking of the aortic valve, it's seeing the backflow of the blood from the aorta. It is also seeing increase in afterload because the stroke volume goes up, because that blood that's leaking into the left ventricle needs to come back out. So this is not so much black and white. It's a little bit gray. It's a little bit gray because you're seeing really two lesions. You're seeing a volume lesion, but you're also seeing a pressure lesion. So not only the left ventricle dilates to compensate for the volume lesion, the walls of the left ventricle also become a little bit thicker because it's compensating for the pressure lesion. So the aortic regurgitation is probably one of the more complicated lesions to talk about. Okay, so anatomically wise, let me change back to the pen here, or to the arrow rather. So this is your normal aortic valve. In diastole, it's closed. And here, the aortic valve is leaking. So in diastole, there is blood flow going into the left ventricle. So the left ventricle is being filled by the blood flow from the left atrium, as well as the backflow of the aortic insufficiency. Now, pressure-wise. So we have blood flow coming from the aorta, blood flow coming from the left atrium. The left ventricle is dilated, and the left ventricular wall is a little bit thicker. So not only are we seeing that the left ventricular end diastolic pressure is higher because it's a little bit stiffer, and the left atrium has to fill it at a higher pressure, it also fills it at a higher pressure because there is more blood volume there. So the higher the volume, the higher the pressure. And because of the increase in stroke volume, the aortic pressure goes up. So your left ventricular pressure is going to have to be higher. So it's both volume and pressure lesion. As I said, it's more complex. Now, because there is continuous blood flow between the aorta and the ventricle, the aortic diastolic pressure drops. And so you have a higher pulse pressure. Pulse pressure is the systolic minus diastolic. So 160 minus 60 is 100. Here, 120 minus 80 is 40. So the pulse pressure in patients with aortic insufficiency is higher. You also see this in patients that are elderly because their peripheral vasculature is stiffer. So you see a higher pulse pressure as well. And so here, we talk about pathophysiology. When you have increase in volume, you have increase in wall stress. The way to decrease that wall stress is that you increase the left ventricular stiffness, you dilate the ventricle, okay? But because of all that, you end up with left ventricular fibrosis, okay? And here you have a Venturi effect, which I'm not going to worry about. But what I wanted you to show is that there is remodeling on the cellular level, and these myocardial cells become very unhealthy. And so your diastolic function becomes problematic in patients with significant aortic insufficiency. Okay, so let's talk about acute aortic regurgitation. So again, somebody with endocarditis, the valve's destroyed, and now you have backflow of blood between the aorta and the left ventricle. So what you see here is that this is the aortic blood pressure form, and this is the left ventricular pressure form. You see that there is continuous, this is diastole here, there's continuous blood flow between the aorta and the left ventricle. So look at what's happening with the left ventricular end diastolic pressure. It rises rapidly until it reaches the aortic end diastolic pressure. So basically what this means is that the left ventricular end diastolic pressure is equal to the aortic diastolic pressure. So if your aortic diastolic pressure is 60, that's what your left ventricular end diastolic pressure is. So that ventricle is operating at a very high preload. All this blood flows right back into the left atrium, right back into the pulmonary vasculature, significant pulmonary edema, drop in cardiac output. These people are extremely sick. This is left atrium waveform. This person actually has third-degree heart block because you see all these atrial activities, and this person had aortic valve abscess. So this guy was extremely sick. Now, pressure volume loop, again, operating at a very high filling pressure. The stroke volume is down. The contractility here, even if we don't change the contractility, your pressure volume loop is shifted to the right. And notice the isovolumic relaxation it's not isovolumic here. It is sloped. And the reason it's sloped is because there's continuous flow between the aorta and the left ventricle. And this is very similar to mitral regurgitation, except the mitral regurgitation is systolic lesion, and the aortic insufficiency is a diastolic lesion. So the isovolumic relaxation is reflective off of that. Now, shift gears a little bit. Chronic aortic regurgitation, similar pattern, but much less acute, can develop over years. If you look at the aortic pressure curve, you can see that the diastolic pressure is lower because there is continuous flow between the aorta and the left ventricle. But the left ventricular end diastolic pressure curve is much less. It certainly does not meet right here. It doesn't go up straight as what you saw in acute aortic insufficiency. And again, there is no gradient between the left ventricle and the aorta because the aortic valve opens fine in systole, but it does not close in diastole. So you have elevation in the pulse pressure. Normally, this curve should be up here, and in somebody with aortic regurgitation, this curve is down here. Pressure volume loop in significant aortic regurgitation. Again, you have increase in volume, so your stroke volume goes up. Now, most of that stroke volume does come out the left ventricle, and that's why we have, this is more of a combination of the pressure and volume lesion, and the pressure comes in because of the increase in the volume. And this is what happens when you decompensate it. Again, as the left ventricle dilates, you get to the point where you can't dilate anymore, and then your contractility line drops. And because of that, you're going to fill it at a higher, much higher pressure. So your diastolic filling pressures go up. And so not only you have low cardiac output, but you also fill at high pressure. So you have backflow of blood into the lungs, get pulmonary edema, and you have problems from that end.